Thank you, Sushmita, for having me here. Okay, obviously, Vinay has already said that it's a progressive optic neuropathy, and you are going to lose cells as you age, and there will be some kind of progression anyway. But anyway, we have to figure that out, and we have to try and give a good function till the end of the life. And how do we monitor it? Obviously, you can have functional tools in which we have fields, or we have structural tools like disc photography, imaging, and but very important thing is many a times we just neglect the patient by itself, and they will be saying, sir, something is not right. I feel that things are going down, and we think that this old man is just grumbling here. But what basically happens is that the patients sometimes get a very good sense. So you also please have a look at what they are saying and see if the IOPs have started rising a little bit from the previous ones, and you would know that something is happening over there subtly. Obviously, this chart is age old, and we all know that in early stages the RNFL gets affected, then the disc and the visual fields, though sometimes the things can be other way around. So this is one patient that came to us, 620 microns, a 50-year-old male. All the pressures were between 20 and 24. OCT was normal, fields absolutely normal, disc is perfect. There is nothing over there. We said, okay, we'll just follow him up. And 1 year down the line, the first thing that changes is that there is a wedge defect. So the first dictum is true that it was an RNFL defect which came up. The disc is still very difficult to make out if there is a notch. The field is still normal, and obviously in OCT there is a progression. So yes, we do know that this can happen. The one to my mind, and especially if you are in a small setup, the best tool indeed is your mind and your brain and your eyes. So keep looking at the disc very importantly. Please dilate, have a look at the disc. That will give you most of the answers in the early stages. And if you like, we have already said, if there is a disc hemorrhage, obviously you are worried. If there is a bearing of the circumlinear muscles, that means that some of the RNFL over there is dying. Again, if the wedge defect is there, the notch you are not going to miss, but if the wedge defect increases, you know that something is not right. If the rim is getting thinned out, again, if there is a notch which is occurring. Another very important thing which has been stressed, I'll stress again, please repeat your gonioscopies. That is also progression. If the angle is closing progressively, that means something is not right over there, and you have to take action over there. But the gold standard obviously is the visual fields, and you have to check for new defects, enlargement of pre-existing defects, and deepening of defects. And obviously there are a number of ways by which you can do it. The most easiest is just take out a number of printouts and check whether things are going down. Then came the glaucoma change probability analysis. The problem was that it was based on raw data, which could be affected by learning curve, cataracts, and so on and so forth, so which was not very popular. Then came the GPAs, which was dependent on the deviation numerical plots. For this, you basically need two good visual fields. So we were discussing all the time, please do two fields which will give you symmetrical results, so that we can have a good baseline, and everything else that you do will be taken up from there. And then you can feed it, and when you have many more examinations, the machine themselves will tell you that if there is a likely progression or there is a possible progression, and then you can really take it from there that yes, if there is a progression, we will act accordingly. And obviously VFI is also another indicator which takes into account both primarily the central effects, and both the pattern and the total raw data also is taken into account, and this can really tell us the rate of progression. So that is one of the best indicators to gauge that what exactly is going to happen in the future and how aggressive should be with our system. So fields are really good. They are still our gold standard. The problem is learning effects. So again, you can delete the learning effects by having two baseline symmetrical fields. Long-term fluctuation is there, so you can have fields which improve, become worse in the middle, but we have to be careful. Again, even in worsening fields, you must have two symmetrical worsening so that you know things are okay. If it's an already bad field, be very careful. Don't go on any PhD, MD and all that. Just take raw data and closely study step by step how much deviation is there at each point, and that will how much decibel power is there, and that will tell you where things are headed, and you have to look for other pathologies which could be there which are troubling us. So good baseline fields, two of them symmetrical, always confirm suspected progression. Clinical correlation is important. Another patient, 48-year-old male, came to us, myope, initially normal in 2008, was not on any treatment, then came when 2016, when mild changes have started occurring in both the eyes, put on one medication, disappeared for a year, the fields have become worse, and then again came yearly, religiously he comes, and again the fields have become progressively worse. And the OCT also shows us that there is a progressive worsening. But the discs in these cases are not so clearly defined, and though initially you can see that yes, the wedge defect is there, as in the current you see that the wedge defect has not really increased, whereas the fields have increased. So why does this happen? Usually in early disease, RGCs are lost, surrounding cells perceive the visual target and they report the target as being seen. So in visual fields, in very early things, there may be that the dead areas are still being seen and the visual field may be stable. And why function before structure? Already structurally advanced, in advanced cases the axons are dead, but they are still lying over there, and so they are perceived as being present. So there again you have to be really careful. But we have now OCT tools, again just like a GPA, they can give you p-values to show if there is a statistically significant change in the OCT itself. But again, and this Cirrus, these are Sushmita's slides themselves, they can also tell you trend of the RNFL thickness, trend of the cupping as well. And what she wrote in a paper was that yes, OCT was more useful to detect progression in early glaucoma. Again, as we showed you, in early changes, yes. In late changes, it may not be as good. Again, if to see an example, a difficult disc, many a times these myopic discs, difficult to know out what is happening. Visual field and OCT both look progressed, but when you really do an image quality analysis, you find and improve the image of the take up, you find that the downward slope is reverted back. Again, left eye disc looks normal over 5 years, visual field is stable, but then when you see at the baseline, you realize that the baseline is not the same and as what was, so there are no symmetrical baselines, plus the take-up factor over here is not good in the follow-up things. So you have to really chart out whether the OCT has been taken properly, whether the baseline was proper or not. Basically, progression is not easy to evaluate. Judge very carefully, do multiple tests to make sure that actually progression has occurred, because it will need a drastic action, either an increase in medication which may cost the patient a lot, plus, or you may have to do a surgery, which again is quite a drastic step. Both functional and structural progression may occur exclusive to each other. Poor concordance between structural and functional tools many a times, but for early stages we see that structure is good, so you can do a disc assessment, you can look at OCT, but for advanced cases I think the field will do the trick for us. Thank you very much.